usually see this form. Also, it's picked up during maternal screening, where you can have elevated levels of serum alpha-fetoprotein. Major risk factors, we already heard one of them, the major one being folic acid. Other ones include diabetes, morbid obesity, and some pharmacologic agents. So there are a number of things that can result in this. But we usually pick it up in the second trimester, and either these patients become candidates for what is becoming routine now with fetal surgery, or they're delivered and are closed postnatally. The treatment usually is immediate, especially if there's a CSF leak for risk of meningitis, so immediate being within 6 to 12 hours. Otherwise, they're typically closed within, the books will say 72 hours, but most of us who practice will make a concerted effort to close these within the first 24 hours for the theoretical, again, risk of infection. They're typically closed primarily, usually this was the days when mostly neurosurgeons did these, and so they just closed them primarily midline, dural closure, followed by fascial closure, followed by skin if you needed to, and to further relax if you had to. But as children are living longer, as defects we're picking them up earlier, they're larger, we now needed some other types of mechanics and expertise to help assist with closure, especially of these larger lesions. And so that led to the development of many types of different musculocutaneous and different skin types of grafts and flaps that I'll discuss briefly. As many of you have discussed, this is a multidisciplinary approach, especially at this point and at our institution. We certainly involve plastic surgery to help close these, especially when they entail the larger defects that may require some of the more advanced type of flaps. There are many different types of closures. Some of them, I'm sure a lot of you guys are familiar with them. They range from primary closure to bone, muscle, skin flaps, to multiple rotations, to luteal pull-throughs, a lot of different types. And there really hasn't been a stratification as far as how and when to use which one. We'll kind of discuss that in a little bit. But suffice it to say, irrespective of the type of closure which is chosen, there are complications with each of these, and these include significant blood loss for the longer operations, and we'll talk a little bit about that. CSF leak is the big one that can often happen, and sometimes can really, unfortunately, undo some of the advanced flaps that we've done, infection, and then in some cases tethered cord. And the great debate has gone, and especially in the neurosurgical world, regarding whether or not one needs to really close this placoid and really reassimilate it into the neural tube versus just closing the dura and doing some of these other things to make the procedure a little bit more efficient. But I think most of us who do it will try to make a very good attempt to close that neural placoid and reform the neural tube embryologically. So a good outcome is really dependent on a good decision rule tree as far as when and how to use which type of structure. And so a lot of this, as this has become more and more prevalent, we've seen the discussion of flaps and which types of flap really enter into the neurosurgical literature, which it hadn't really been before. Others have discussed primary repair versus some of these other flaps. And I think for reasons of its simplicity, efficiency as far as time, and then blood loss and hospital stay, primary closure has a lot of data and usually not as morbid. But as we're coming to see now with more and more of these being done, is that you can certainly get the cosmetic results, if not better, but also have reduced morbidity with some of these other type of flaps as well. So this was a technique described by Ramirez in the mid-80s, where this was a bilateral bipedical type of flap in which he used both latissimus and gluteal muscles to close a large defect. This defect is particularly interesting because, unlike most, this one is more horizontal per se than it is vertical, and so it presented quite a challenge. And I know myself, I can't speak for all neurosurgeons, this would pose somewhat of a problem for us to try to close that without producing significant tension along the closure lines. And so this was not the first technique described, but this is one of several which included, and this one again is a musculocutaneous flap, but a very good one. And so what Ramirez ended up showing is that although operative time may have been increased, hospital stay compared to other procedures, as well as some of the complications, was the same, if not better, versus primary and other types of closures. So what we now begin to see is that these type of big flaps, if done properly, can really result in good closure with good outcomes. So I'll quickly kind of just gloss through a number of them. This is a superior gluteal artery perforator flap closure, and again, this is used for large myelomeningocele in which a portion of the gluteal tissue is then superimposed after primary closure by the neurosurgeon, superimposed on the defect. And these result in really good cosmetic closure as well as coverage of the initial defect. And so this is just it in illustrative steps. The primary closure, getting the gluteal muscle separated to pull through, and what the final procedure looks like. And you can see this is after several years, but very well healed. Not a midline closure, but again, did the job as far as the meningocele closure. Other techniques have come about, but as far as this particular one, the advantages include the tension-free placement, preserving the gluteal musculature, and now can be done successfully in newborns, because obviously a lot of these patients are newborns. It's a technically complex procedure. It does have the risk of higher morbidity, and it's a perimedian type of closure. And the reason I say that is, I often, as well as many of my colleagues, discuss perimedian versus central closures. And so for some of the complications which arise, in particular CSF leak, which require a reoperation, for us, if we don't, at the time of reoperation, have the assistance of plastic surgery, we tend to do better with the midline procedure. That doesn't mean that the original procedure wasn't as good, but we usually would describe things in terms of midline versus perimedian, but a very nice type of procedure. There are also these bilateral latissimus dorsi flaps. Again, this is a pretty round, not necessarily too horizontal or perpendicular, but by use of the latissimus dorsi flaps, we're able to, in essence, after a primary midline closure, then rotate and end up with a very nice closure with very good cosmetic results. This one is relatively simple. Again, provides nice cosmesis, and it's a midline type of closure. Not always, because a lot of times you need the Dopplers for that, and they're not always routinely available at all institutions. But that's a very minor disadvantage, to be frank with you. Dermal regeneration has been used to close these, so oftentimes you may see, in fact, Integra has developed a silicone dermal matrix implant, and not to give them any particular advantage over anyone else, but this is, again, as you start to see, a lot of these journals I'm picking up are in the Journal of Neurosurgery, so you guys' literature is probably rampant with these, but we're starting to really see the influx of some of these techniques into our literature, and so we begin to see that. So this particular one, again, will address via a dermal regeneration template, which uses silicone and a glycosaminoglycan type of matrix to help close the tissue. So I'll show you just a quick case. Again, a pretty large defect, and after the midline closure and fascial closure, this dual substrate template is placed on. It stays on for a little bit, but then the silicone part of it is subsequently removed, and a split thickness graft is then employed and covered and protected. This results in, again, pretty nice closure of an otherwise large defect. Another thing about this, again, it will require multiple surgeries, unlike some of the others, but is an alternative. And I'll quickly just go through others. So this is the use of tissue expanders. So you guys have used tissue expanders for a number of different types of closures for other defects in other parts of the body. But now we're starting to see this employed somewhat frequently for the closure of myelomeningocele. So over time, these implants are placed bilaterally. They stretch the skin and allow for fairly good coverage, and again, a nice midline closure. The advantage of this in particular is that there's no interference with the musculoskeletal structures, therefore not compromising the ability of future surgeries, especially of the spine, and you retain the functionality of the regional muscle groups, which is a big thing. So Daryl quickly got into the fetal surgery. So now that was the open delivered babies, and now we're starting to do these procedures a lot earlier. And so it's not just at this point the neurosurgeon who does the closure. In fact, they're pediatric surgeons, they're fetal maternal medicine individuals, but a lot of new techniques are being employed in the use of fetal surgery. So I'm happy to be a part of that. But typically at this point, most are done from an explanted uterus. The defect is then made visible, closed primarily, and then reimplanted. But like Daryl alluded to, we're now delving into the world, and Houston has been a big leader in doing this, of some of the fetoscopic repair as well too. So we'll now start to do those patients who are good candidates fetoscopically, and we've heard some of the great advantages of this, in particular to the mother. So only time will tell, but I think if you get the longevity that we've seen, at least with the open procedures, and you're able to transpose this in the fetoscopic repair, that would be a huge benefit moving forward. So we've seen in a very short time how it's gone from just a neurosurgeon to a combined approach, and now in utero, and it's a very, very exciting field at this point. So I'd just like to again thank Dr. Pape, Dr. Rapazo, and actually Dr. Nasiri for inviting me to this talk, and the ASMS, and I am happy to conclude my presentation this morning.
So we'll conclude this section now by inviting Dr. Leclerc up here from Michigan to talk about the plastic surgery component of treatment of the open to defects. Christian.
Great, thanks. Thanks, Dr. Pape, the ASMS, and Antonio Bahar for allowing me to talk to you guys today. So, as was mentioned earlier, about 85% of these myeloma seals occur in the lumbosacral area. And as a young plastic surgeon walking into the room seeing one of these can be quite daunting to try to figure out how are we going to get this closed up. You can see that there's a lot of abnormal tissue here. The plaque that's overlying this area is unusable for anything that you can close. You can see on the image on your right, you can see the duro repair there. And there's the bony elements laterally that you can see sort of in the white. Your bony elements here are quite wide. So how does one prepare yourself to fix something like this? Well, we had a nice sort of overview and a review of the literature. I'm going to simplify it and make it really easy. I have an algorithm that anyone here can take care of this very simply without anything too complicated. So again, here's a schematic of showing where the most common myelomeningocele defect is. And you have at your disposal the thoracolumbar fascia and the latissimus dorsi muscles, as well as the paraspinous or rectus muscles. So your local and regional options are the thoracolumbar fascia, the lumbosacral fascia, and then the paraspinous or rectus and the latissimus dorsi for defects that are higher. So how do you sort out what flap you're going to use? Well, if the defects is pretty much dictated by the anatomy of the individual patient. For defects in the lumbar region, paraspinous flaps are a workhorse, and also this can be combined with the fascial turnover flaps, and I'll show you explicitly how to do that. And then for the defects that are slightly lower on the sacrum, there's not as much muscle to move around. You want to avoid moving the gluteus maximus muscles because those are hip stabilizers, and these patients can have trouble with gait given their neural defect. And so you really want to avoid undermining or messing with the gluteus maximus muscle. But you can do a fascial turn down. So what do I mean by fascial turn down? So here's a nice anatomic depiction of the thoracolumbar fascia up here, and the lumbosacral fascia down here. You make an incision and dissect that fascia down off the overlying muscle and turn it down. You can cover a low defect down here. You don't want to move those muscles. So if the defect is right there, you can bring that down and cover it. So that gives you a good coverage of your dural defect with non-coincident suture lines, which is essential for preventing any sort of leak or infection. If the defect is a little bit higher, you can actually incise these laterally and then dissect lateral to medial, keeping the blood supply medially based on this fascial flap. So to describe that a little bit better, this is a cross section. So you undermine the skin widely, and then incise the fascia laterally. If it's difficult to find the plane, a little hydrodissection, injecting some just normal saline into that plane can help you find the fascia. And a 0-day old or a 1-day old, this is a very, very thin layer, and if you're not careful, you can buttonhole it easily. As you advance medially to get extra length, you can incise the periosteum on the lateral bony elements and further dissect on the periosteum to mobilize that flap, so that you can close that together in a pants over vest fashion or double-breasted fashion, whatever your sartorial taste may be. But to basically have 2 layers of healthy vascularized tissue over that dural closure with non-coincident suture lines. So about 10 years ago, or a little less than 10 years ago, we looked at our experience using these, and the vast majority of our defects we could close with paraspinous muscles and the lumbosacral fascia, a combination of those. The lumbosacral fascia alone was less frequent, only about 30%, and then some combination of those flaps I just described for the rest of them. So how do you close the skin? Well, simple linear closure is the most effective thing. So the idea that you can't close these under tension isn't quite correct. These babies have, we saw that how fetuses can heal amazingly well. But these 0-day-old babies and 1-day-old babies, if you close this under tension, it heals just fine. And a lot of times you can put a O-Prolene pulley stitch in and allow for a little dermal relaxation and creep. And you can close this in a straight line without having to do a lot of complicated origami zigzags on the child's back to avoid any further scarring. In our series, 67% were able to be closed in the midline. My personal experience over the 5 years that I've been doing this, I've always been able to close them in a straight line without having to do a long-wood flap or any sort of rotation flap. Post-operatively, neurosurgeons are usually opposed to JP drains in general. If you tell them you're going to leave it superfascially and away from the dural closure, and you have good, healthy tissue covering their dural closure, they'll allow it, and I think that's critical for avoiding post-op seromas because the output, as I showed you, the dissection is relatively extensive. I put in these wounds are in the diaper area, so a nice occlusive dressing of Telfine Tegaderm is nice to keep on there, and then when it gets soiled, you should change it. And I'm pretty draconian about keeping the child offloading, and these kids all go home from the hospital in a car bed, not a car seat. A traditional car seat puts pressure right on this area, where it's a very thin closure that you just close, as I said, under tension. But doing this, you can get nice results in virtually every single patient with straight line closure. All of these kids will usually have some amount of capillary staining around this, which is important to warn the nurses and the parents that this is not an infection. That's just the capillary staining that there's nothing to do with. In our series that we looked at over the first 15 years that Dr. Buckman did these, there was about 20% skin separation. The infection rate is quite low though. When you use these large fascial and combination fascial and muscle flaps, you know that you've got good, healthy tissue, durable tissue covering your dura, and any little skin hiccup doesn't really cause a problem because it's granulated. But about 1 in 5 had a little bit of separation. There were no CSF leaks in our series and no seromas or hematomas. We're currently looking at our data since 2010 to update these numbers. So in summary, local and regional muscle and fascial flaps with simple skin closure over the top of those flaps provides reliable and durable soft tissue coverage of myelin and endothelial defects with minimal complications. Thanks.
Well, seeing as how we are eating into our sacred lunch hour, let's keep this a little bit short. But if there's any questions out there from our panel, Dr. Buckman, I see your hand.
My question is for the neurosurgeon. At Michigan, we also are very involved with tethered cord repairs, and we have our data also showing almost no leaks, which is sort of a big difference in comparison to those that have been published in neurosurgical literature. So on every one of those, actually, we're actually putting in flaps and so on. Do you do that here? Is that something that you think is more common? Because Dr. Marasco really thinks, and Dr. Garten and Maher trained up at Mass General, and he said that the leak rate was, he makes the case that the leak rate is significantly lower since using these fascial and muscle flaps even for tethered cords, and I was wondering what your thoughts were.
Yeah, thank you for that question. I think what you're seeing now is really a transition. I think the people that are doing these multi-layered closures, the number one thing is they do provide a good barrier because it's not just the dura, it's a number of different layers, and I think that attests to why the CSF, partially why the CSF leak may be lower. I'll tell you, when I was in fellowship, I had a combination of attendings who did different things, and I had one in particular who always did his own closure was able to do it fairly well. But then what I've also seen is that when we do it in conjunction, especially with the grade closure, we get good cosmesis and we kind of really decrease some of those complications we talked about. So I've really started to move more of the combined approach. I let our plastics guys decide what type of flap they use. I'm frankly learning more about the different flaps because there's so many different kinds you can do. But I think the people who do what they do a lot, I think that's really what makes a difference. Not so much the type of flap. I think the type of flap really can determine, for instance, if you're using muscle, it can determine other things like to develop. What we're starting to see now are these huge flaps. Are they contributing to, say, scoliosis or some other different types of things? And so I don't know that the jury is out there. But I do think they provide a very good barrier, and that's why probably some of, especially CSF leaks, are low. So again, in summary, I think I've tended to use a combined approach. I like that. I think, our guys here do a phenomenal job with the closures, but I let them kind of just decide what types they would use. Thank you.
We have a question from Dr. Jarofsha.
Christian, Christian, I enjoyed your talk. I've tried to close these, and I've always debated whether I should just close the fascia versus closing the muscle, and especially inferiorly as you go quarter, you end up not being able to close the muscle because it's too high unless you take it off the iliac crest. And then I spoke to Chris Forrest, and he said, why are you doing that? We just close the skin. What do we do? Do we close the skin? Do we close the muscle? Do we close the fascia? Do we have any evidence one is better than the other?
I'm not sure if we have any evidence that one's better than the other. We're again reviewing an update from that paper that was published about 8 years ago. Maybe we'll hopefully shed some light on that. I tend to cover everything, and I cover with muscle what I can cover with muscle, and then I cover with fascia. And if there's a really inferior defect, I'll turn down that thoracolumbar fascia so that I have a good coverage. I think the issue is that because I'm usually committed to closing these in a straight line closure, because I think that's the best type of cosmetic closure for that area, that sometimes you have to really hog it together, and I want good coverage over everything in case there's any hiccup in the healing process.